Hey, Sacramento Report Fire, it's Dr. Mackey. Let's talk about cardiac dysrhythmias. In cardiac dysrhythmias, which is policy 8024, there are two major points, bradycardia and tachycardia. Let's talk about adult bradycardia first. Big thing here that gets missed a lot is you want to make sure that these patients are symptomatic with a heart rate less than 50, a systolic blood pressure less than 90, and other symptoms of hypoperfusion like decrease in sodium, diaphoresis, chest pain. Other things included here are cyanosis and cool extremities. So it's not just the heart rate, it's the heart rate plus lower systolic blood pressures and symptoms of hypoperfusion. Remember that you can use supplemental O2 if their SATs are less than 94. So in these patients, what are we going to do? We're going to put them on a monitor. We're going to get a 12 lead. We're going to start an IV. We're going to titrate blood pressure to greater than 90 with normal saline. If they are symptomatic and they have a type 2 second degree block or a third degree block, I want you to begin pacing without delay. Don't reach for the atropine. Don't wait for things to get started. Start pacing them. If you're going to give atropine, you can give atropine 0.5 milligrams IV or IO. Now, after you've done that, what happens if they're persistently symptomatic? If you're pacing them, then you adjust the pacing. If you've only given them atropine, that's when you institute pacing. And remember that when you're going to pace somebody with this, it hurts and it causes anxiety. So you're going to need to use midazolam if you need it for sedation. I want you to remember the intranasal route, the IN route. It's fast, it's quick, it's easy, but it's IV, IO, IN, or IM, 4 milligrams, and you can give an additional 2 milligram dose if you want to. So what if you've done transcutaneous pacing, you've given them atropine, and their blood pressure is still low? In those situations, if their systolic blood pressure is still less than 90, this is a situation where you can use push-dose epinephrine. The dose is 0.5 to 2 mils, which I'm going to tell you a little secret. In every protocol, it's 0.5 to 2 mils. IV or IO every 2 to 5 minutes and titrate for their blood pressure to be greater than 90. And then, of course, you should institute transport as well. Okay, that covers bradycardia. Let's move to tachycardia. Okay, everybody, moving to the tachycardia algorithm. This is going to be for narrow QRS complexes with a heart rate greater than 150 or wide QRS complexes with a heart rate greater than 120. So again, let's start with the basics. Is the person hypotensive, confused, showing signs of shock, having chest pain? These patients are unstable, and we're going to move quickly to synchronized cardioversion in these situations. Remember, synchronized cardioversion is uncomfortable. You can give them midazolam at 4 milligram doses. Again, reminding you intranasal routes are preferred here because it's going to take a while to get the IV or the IO, and IM is just going to hang out in the muscle. So IN, intranasal, is preferred. Once you give them that 4 milligram dose, you're going to synchronize cardiovert them at 100, then 200, and then the max setting. So let's pop over if they're not hypotensive and have chest pain. There needs to be an assessment of the width of the QRS. If the QRS is wide, then you're going to just transport them and consider contacting the base. If it is not wide, then you're going to look at it and see if it's AFib, aflutter, or sinus tach, because oftentimes it is those. Especially in our older population, rapid atrial fibrillation, or what's called AFib RVR, which is rapid ventricular response, is not uncommon. So it could be a narrow complex that's irregular but fast. If you think it is AFib or aflutter or sinus tach, then again, you just transport. However, if it's narrow and not AFib, aflutter, or sinus tach, then you're thinking about SVT. And in SVT, you know where I'm going with this, starting with a Valsalva maneuver. And if there's no response to that, you're going to give them adenosine, 6 milligrams rapid IV, followed by a flush. So we will go through some of this with the mannequin, but 6 milligrams given as close as you can to the IV insertion site with a rapid push of 20 cc's of normal saline after that. You can repeat adenosine at 12 milligrams if you're still thinking it's SVT and it did not work. Okay. So let's pop back over to the synchronized cardioversion. Let's say like you've done your synchronized cardioversion. At this point, you're still going to do an assessment of the width of the QRS. If the QRS is greater than 0.12 seconds and they are stable, then you can give them an antiarrhythmic, which is amiodarone. It is an antiarrhythmic. Amiodarone, 150 milligrams IV or IO over 10 minutes is the preferred way if they're stable and you transport them. If they are not stable, you can give 150 milligrams IV push. So the key here, stable, not stable, following synchronized cardioversion with a wide QRS. If they are unstable, you're going to push the amiodarone at 150 milligrams. If they are stable, you're going to push it slower, really. It's over 10 minutes, 150 milligrams. Basically, it's the speed at which you're going to give it. Now, if the QRS is not wide following your synchronized cardioversion and they are stable, you're just going to transport them. But if they are not stable, you're going to go back to the synchronized cardioversion and you're going to use maximum energy. Okay, this is a long protocol. It's going to take some time to digest and go through it. I suggest you spend a little time with it. I want to remind you guys that 12 leads are important in these patients, but they're not essential and they should never interfere with your patient care. The first step in both bradycardia and in tachycardia is the stability of the patient. Unstable patients need to be treated quickly. Bradycardic unstable patients, you run right to transcutaneous pacing. Tachycardic unstable patients, you run right to synchronized cardioversion. Okay? All right, guys, hope that works and hope that's good for you. And send me any questions you got. Thanks so much.